Hi, this is Patrick Pruitt. Today I'll discuss a 66-year-old male with ascending cholangitis who presented to the ED with fever, hypotension, and altered mental status. Um, he was taken emergently to the OR for ERCP, when to the ICU following that for volume resuscitation and pressors. A couple of teaching points about cholangitis. Of course, you know it's a blockage of the biliary system, usually by a stone around the sphincter of Oddi or the ampulla vater. What happens is there's a reflux of a pure material into the lymphatic system or the biliary system, portal system, that begins the septic cascade. This is usually due to a gram-negative bacteria, a anaerobe, or enterococcus. So, starting point there is, of course, gram-positive, gram-negative coverage, wide spectrum. A couple other teaching points for this guy. There's something called Charcot's triad. It involves fever, jaundice, and right upper quadrant pain. He met all of those. This only happens in about 25% of patients. The other thing is called Reynolds pentad, which involves all the findings of Charcot's triad, plus hypotension, shock type symptoms, as well as altered mental status. And this only happens in 14 or 15% of patients. This guy had both of those findings, which made him extremely sick. He was felt to be acutely ill and very critical situation. It's important to note that this isn't treated, that carries 100% mortality. So now I'll present Mr. J.M., a 66-year-old male with ascending cholangitis. HPI, 66 male presented to the ED following 3-day history of fevers, chills, nausea, vomiting, and progressive abdominal pain. On arrival to ED, he was acutely ill. His abdomen was exquisitely tender. Sclera and sublingual mucosa were jaundiced. Abdominal ultrasound showed dilated duct, and CT abdomen showed obstruction. GI was consulted. He was taken emergently to the OR for ERCP. A stone was swept from common bile duct and purulent sludge was noted. He was then transferred to ICU for pressor support and fluid resuscitation. 24-hour event involved resolution of his fever and winning of the pressors up to midnight. Assessment and plan. Neuro. Alert and oriented time is 3, GCS is 15. Exam. He is somnolent but appropriate when aroused. Pupils are 2+, equal and reactive. Extraocular movements are intact. Sclera are icteric, conjunctiva pale. Mucous membranes are moist. Oral pharynx without sores, lesions, or ulcerations. Sublingual mucosa are icteric. Plan. No acute issues. Will continue to monitor. Cardio. Cardiac, heart rate 80, BP 106/69, MAP 82, Telly sinus rhythm, CK is 480, MB 7.2, troponin 0.30. Exam S1, S2 are present, regular rate and rhythm, no murmurs, rubs or gallops, capillary reflow is breast, no JVD, no peripheral edema. Plan, troponin is trending down. Elevation likely due to ischemic demand. Aspirin and Lipitor were added overnight, and will continue to monitor. Pulm, respiratory rate is 17, SpO2 is 100%, O2 is at 3 liters per nasal cannula. Chest X-ray shows the elevated right hemodiaphragm, which is going to be for atelectasis or possible subdiaphragmatic abscess. We will plan on continuing to provide O2 3 liters per nasal cannula and start easy PAP treatments with dual NEBs Q4 hours, increase activity as tolerated, and start incident spirometry. Q1 hour chest X-ray findings will be discussed with the GI, and we'll plan for a CT this morning. Renal, INO 2209, 500 out, positive fluid levels at 1709, GFRs around 40 cc's per hour. Renal panel 139, 3.8, 114, 1861, 2.686. Calcium MAC 5, 7.0, 2.4, 2.8. Lactic acid 1.8, and gas 11.4. Plan, replace electrolytes per protocol. He'll be given 2 grams of calcium gluconate this morning, and we'll follow his electrolytes Q6 hours. No, he has a known history of chronic kidney disease. His lactic acidosis is resolving. We'll continue to monitor this with the renal panel. GI, weight is 219, BMI is 29.8, albumin 2.4, T-belly 6.7, D-belly 4.7, outward price 27, GGT 107, AST 241, ALT 158. Exam, abdomen is soft and tender to touch with hypoactive bowel sounds. He's solid and distended. Elevated bilirumin and transaminases are due to biliary obstruction. and turning downward. We'll start clear liquids this morning, and advance is tolerated. We'll continue to monitor. ID TM99, TC 98.8, WBC 16.2, blood culture depending, wound culture depending. Currently on Zosyn 2.25 milligrams Q6 hours. Has been renally adjusted for his GFR. Usually the one-time dose of vancomycin in the OR. Plan to continue current antibiotics. Await culture results. Heme, H&H is 10.5 and 31.6, platelets are 78, PTINR 16.9, 1.52, PTT at 37.9. He is thrombocytic due to consumption from sepsis. We'll continue to monitor daily CBC. Endo, glucose is 86, no acute issues. Musculoskeletal moves all extremities equally, about 5 strength. Skin is clean, dry and intact, no skin breakdown, no rashes, no ulcerations. No acute issues there. Prophylaxis includes GI, Nexium, 8 milligrams an hour times 72 hours. We'll transition to PO following completion of IV dose. And VTE prophylaxis is SCDs. Will hold his heparin for now due to his thrombocytopenia. Thank you. This concludes HMP number 1.